Continuing on with ATI Chapter 19, Considerations for Oxygen Delivery Systems, Preparation of the Client. Explain all procedures to the client. Place the client in semi-Fowler's or Fowler's position to facilitate breathing and promote chest expansion. Ensure that all equipment is working properly. Ongoing care. Provide oxygen therapy at the lowest flow that will correct hypoxemia. Assess, monitor respiratory rate, rhythm, and effort, lung sounds, and SaO2 to determine the client's need for supplemental oxygen. Manifestations of hypoxemia are shortness of breath, anxiety, tachypnea, tachycardia, restlessness, pallor, or cyanosis of the skin or mucous membranes, including adventitious breath sounds and confusion. Manifestations of hypercarbia, which is elevated levels of CO2, carbon dioxide, are restlessness, hypertension, and headache. Monitor diagnostic reports that show information related to oxygenation, including ABGs. Promote good oral hygiene and provide as needed. Promote turning, coughing, deep breathing, use of incentive spirometer, and suctioning. Promote rest and decrease environmental stimuli. Provide emotional support for clients who appear anxious. Assess nutritional status. Provide supplements as prescribed. Assess, monitor skin integrity. Provide moisture and pressure relief devices as indicated. Assess, monitor, and document the client's response to the oxygen therapy. Titrate oxygen to maintain prescribed oxygen saturation. Discontinue supplemental oxygen gradually. Interventions. Monitor for manifestations of respiratory depression, such as decreased respiratory rate and decreased level of consciousness. Notify the provider if findings are present. Respiratory distress. For respiratory distress, you want to position the client for maximum ventilation in Fowler's or semi-Fowler's position. Complete a focused respiratory assessment. Promote deep breathing and use supplemental oxygen as prescribed. Stay with the client and provide emotional support to decrease anxiety. Promote airway clearance by encouraging coughing and oropharyngeal suctioning if necessary. Complications can include oxygen toxicity, Oxygen toxicity can result from high concentrations of oxygen, typically above 50%. Long durations of oxygen therapy, typically more than 24 to 48 hours, and the client's degree of lung disease. Manifestations include a non-productive cough, substernal pain, nasal stuffiness, nausea, vomiting, fatigue, headache, sore throat, and hypoventilation. Nursing actions would include using the lowest level of oxygen necessary to maintain the prescribed SaO2. Monitor ABGs, notify the provider if results are outside the expected or prescribed ranges. Use an oxygen mask with continuous positive airway pressure, CPAP, or bilevel positive airway pressure, BiPAP, if prescribed to help decrease the amount of oxygen needed. Use positive and expiratory pressure, PEEP, PEEP, as prescribed while the client is receiving mechanical ventilation to help decrease the amount of needed oxygen. Oxygen-induced hypoventilation. With oxygen-induced hypoventilation, this can develop in clients who have COPD and chronic hypoxemia with hypercarbia. Nursing actions for this would be to monitor respiratory rate and pattern, level of consciousness, and SaO2. Provide oxygen therapy at the lowest flow rate that manages the hypoxemia. If the client tolerates it, use a Venturi mask to deliver precise oxygen levels. Notify the provider of findings of respiratory depression, such as decreased respiratory rate or decreased level of consciousness. Combustion would be another complication. Oxygen is combustible. Nursing action should include to post a no smoking or oxygen in use sign to alert others of the fire hazard. Know where the closest fire extinguisher is located. Educate the client and others about the fire hazard of smoking during oxygen use. Have the client wear a cotton gown because synthetic or wool fabrics can generate static electricity. Ensure that all electric devices, razors, hearing aid, radios, are all working well. And ensure electric machinery, monitors, suction machines are well grounded. Do not use volatile, flammable materials such as alcohol or acetone near clients who are receiving oxygen. Non-invasive positive pressure ventilation would include continuous positive airway pressure. This provides positive pressure using a leak-proof mask via non-invasive positive pressure ventilation device. The device is to keep the airways throughout the respiratory cycle open and to improve gas exchange in the alveoli. Most effective treatment for sleep apnea because the CPAP uses the positive pressure which acts as a splint to keep the upper airway and trachea open during sleep. BiPAP, which is bi-level positive airway pressure, is a machine that cycles to provide a set positive inspiratory pressure with inspiration that takes place, and then during expiration to deliver a lower set and expiratory pressure. This requires wearing a leak-proof mask, most often used for clients who have COPD and who require ventilatory assistance. Nursing actions with BiPAP would include to assess the skin around the mask for breakdown as a tight seal is required, and to check the percentage of oxygen on the machine, both the inspiratory pressure and expiratory pressure when the client is receiving BiPAP. With transtracheal oxygen therapy, you want to deliver oxygen directly into the lungs per a small flexible catheter that is passed through the trachea via a small incision. The oxygen delivery is reduced by 55% for a client at rest and 30% for a client who is active. The catheter is less visible and avoids irritation that occurs from the use of nasal prongs. Moving on to endotracheal tube and endotracheal intubation. Indications for this is a tube that is inserted through the client's nose or mouth into the trachea, which allows the emergency airway management of the client. Oral intubation is the easiest and quickest form of intubation and is often performed in the emergency department. Nasal intubation is performed when the client has facial or oral trauma. This route is not used if the client has a clotting problem. Placement is that intubation is typically performed by a nurse anesthetist, anesthesiologist, critical care or doctor, or pulmonologist. A chest x-ray verifies correct placement of the endotracheal tube. ET tubes can be cuffed or uncuffed. The cuff on the tracheal end of an ET tube is inflated to ensure proper placement and the formation of a seal between the cuff and the tracheal wall. This prevents air from leaking around the ET tube. The seal ensures that an adequate amount of tidal volume is delivered by the mechanical ventilator when attached to the external end of the ET tube. The client is unable to talk when the cuff is inflated. Nursing actions with this are to have a resuscitation equipment to include a manual resuscitation bag with a face mask at the bedside at all times. Ensure the intubation attempts last no longer than 30 seconds and then reoxygenate before another attempt to intubate. Monitor vital signs and verify ET tube placement by checking end-tidal carbon dioxide levels and chest x-ray. Auscultate for breath sounds bilaterally after intubation. Observe for symmetric chest movement. Stabilize the endotracheal tube with a tube holding device or secure with tape. Monitor for hypoxemia, dysrhythmias, and aspiration. Moving on to mechanical ventilation. With mechanical ventilation, we want to provide breathing support until lung function is restored. This delivers 100% oxygen that is warmed, body temperature of 37 degrees Celsius, 98.6 Fahrenheit, and percent humidified at FiO2 levels between 21 to 100%. Positive pressure ventilators deliver air to the lungs under pressure throughout inspiration to keep the alveoli open and to prevent alveoli collapse during expiration. Benefits include the following: forced enhanced lung expansion, improved gas exchange oxygenation, decreased work of breathing, and mechanical ventilation can be delivered via an ET tube or tracheostomy tube. Mechanical ventilators can be cycled based on pressure, volume, time, and or flow, as shown in Figure 19.6, common modes of ventilation, adjunctive therapy, and weaning modalities. This will end page 119 of Chapter 19. We'll continue with Chapter 19 on page 120 next.